I'm going to now introduce Jodie, who is our first speaker. Now, Jodie, we're very privileged to have Jodie here tonight. Jodie is a real expert as a clinical academic. She's been incredibly successful. She works as an obstetrician, particularly in fetal maternal medicine as a subspecialist. But she's also medical director of Women's and Babies Division at the Women's and Children's Health Network, and she's currently an NHMRC Investigator Fellow and Head of Department of Obstetrics and Gynecology at Adelaide University, and a Fellow of the Australian Academy of Health and Medical Sciences. So you can see she wears a lot of hats, but she manages them beautifully and calmly. I've never seen her get cranky. Her research evaluates healthcare interventions in pregnancy and preconception to improve health for women and their babies. She's an international authority in dietary interventions in pregnancy in pregnant women, and been awarded more than 40 competitive research grants, including continuous NHMRC fellowship support, and authored around 190 peer-reviewed publications. So she's a classic example, but she's an exceptional example, a great colleague and friend. So I will hand over there. Thank you, Jodie.
Thank you, Helen, for that very lovely introduction. I'd also like to pay my respects to the traditional owners of the land and acknowledge that we meet on Kaurna land tonight. I'd like to thank you all for coming. It's great that you're here at the end of the day. I hope we can keep you awake and interested. I have to confess, I found this talk exceptionally difficult to prepare. Jocelyn was pretty much contacting me every day, wanting a title for the talk, and it's something that I really struggled with. Where your questions can take you, and I think if I do my job properly, hopefully you'll be able to see that they can take you full circle. I started thinking about what I was going to say at the International Women's Day breakfast, which was earlier in March, and I was very fortunate to hear Catherine Bennell-Pegg speak, who is an aeronautical engineer by training. She's the first astronaut trained under the Australian flag, the first female Australian astronaut, and Australian of the Year for 2026. Now, she was an exceptional speaker. I came away thinking, oh my goodness, what have I been doing with my life compared with all of the things that this amazing person has achieved? And I think I came up pretty much short. She described a story where she was very clear, very early on in her school life, that she wanted to be an astronaut. And she had a very clear focus on asking the how questions, exploring methods, exploring procedures and processes. I was reflecting a little bit, and when I was about 5 years old at school, I was completely enamoured with Egyptology. I remember having a book that my dad had given me, and a colouring book that had all the hieroglyphics and all of the mummies and all of the things about Egypt. And I was convinced that when I grew up, I wanted to be an archaeologist and to discover the pyramids. But that was really, really quickly followed by that little light bulb moment and that dawn of realisation that if I already knew about the pyramids, then how could I actually go and discover them? So I kind of threw that idea out very, very quickly after. Around about the same time, I remember my parents gave me a book, because 50 years ago, you gave your child a book to learn about the facts of life. You didn't actually initiate a conversation. And it was a book called Where Did I Come From? Apparently this is still printed, and it's in its 50th year, which is quite interesting, quite exciting. And I remember me reading that book. It was a hardcover book that had a purple dust cover. And I remember reading that book so many times and being completely blown away by the fact that life could start from 2 cells that were so small that I couldn't even see them. And really building on that wonder and, I guess, sense of excitement, I then decided that when I grow up I wanted to be a doctor. Really thinking through reproductive health, I suppose, and the issues around pregnancy care, babies, how babies developed, the things that went wrong. So moving from those questions of how the embryo develops, how the fetus develops, to really squarely starting to think about why things go wrong, and then really focusing on processes that didn't go quite according to plan and how things might be possible to ameliorate conditions or to change that. I remember as a medical student, again this was way back when, before you actually had to do an interview, it was all based on high school scores. My strategy as a medical student was really kind of to just fly under the radar, to not really draw attention to myself, just do what needed to be done and kind of sit in the back row in the corner and hope that nobody asked me a question. My first introduction to research was as a fourth year medical student, and my supervisor for my fourth year research project was Carolyn Crowther, who worked at the Queen Victoria at the time, the Queen Victoria Hospital, and latterly at the Women's and Children's Hospital. My first paper was a gynae RCT that I did as a fourth year student. This paper was one that you typed up, double-spaced on A4 paper, had multiple copies that you then bound and sent off into the snail mail, hoping that somebody would read them and get back to you. You can kind of see, unfortunately the journal doesn't exist anymore, but you can see just where that red circle is. That was where it was listed as my first publication. I think for me, my next really critical moment as a medical student in terms of introduction to research, introduction to asking questions, came through Geoffrey Robinson, who went on to be a lifetime mentor and friend of mine. I remember in our fifth year O&G exams, we had clinicaloscopy, so you had to go into different offices and answer different questions. One of the questions we were asked was to interpret a CTG or a cardiotopograph, which is a fetal heart rate tracing. And I remember answering the questions, and then we were told, if you finish answering the questions, it's okay to just sit, don't say anything, just sit quietly until the bell goes. So I was very prepared to just sit quietly and say nothing. I didn't realise that Geoffrey had actually followed me into the room. He was kind of doing the surveillance around all of the different stations, making sure that everybody was behaving appropriately. He snuck in behind me, and after I'd finished asking my questions, holding true to the sit still and don't say anything, he asked me a question about fetal heart rate monitoring, and his question was, tell me why we use fetal heart rate monitoring in labour. And I remember taking a deep breath and saying, well, we use it very commonly, and going through all of the scenarios that I was familiar with where we use fetal heart rate monitoring in labour. And he said, yes, that's all very, very correct what you've said. Now tell me about the evidence behind it. Why? Why do we use CTG monitoring in labour? And I remember taking a deep breath and just praying that that bell would go quickly and I could escape. So I had a little bit of a conversation, but couldn't get out of that room quickly enough. And I think for me, Geoffrey has always been one of those people who really does challenge me, or used to challenge me in my thinking, and really stretching me to ask questions and really step outside my comfort zone. Over the course of my O&G training, I did a few little projects and had a few publications, not anything monumental. They were kind of just little clinical audits that happened along the way, but was fortunate enough to get them published as I went, which I think is always a really good thing. If you're going to do a project, make sure it's worthwhile, make sure you can get it published. I then next encountered Geoffrey and Caroline as a senior trainee at the Women's and Children's Hospital, and I remember doing a caesarean section, a very preterm baby caesarean section that we were doing, and Geoffrey was the consultant who was on delivery suite for the day. So we were there doing the caesarean section, and I remember plucking up enough courage and asking him whether or not there would be potentially a little project that I could be involved with while I was a registrar at the Women's and Children's in that year. my thought was that it would be a nice, small, contained audit type project. But very soon after the caesarean section had finished, Jeffrey made it very clear that I was not to waste my time with little audits, that if I was going to do something, I needed to do something worthwhile. And within the space, I think, of 2 weeks, I was enrolled in a PhD and had a protocol for a randomised trial, which was comparing oral misoprostol with a traditional vaginal prostaglandin medication that we use for induction of labour, in which we recruited and randomised close to 900 women. So that was a pretty significant PhD project. That was published in the BMJ in 2006. 2006 was a bit of a big year for me, which I'll go on to in a minute. This is just a little bit of a sideline. I think we all get asked when we're putting in our research applications to be able to describe our impact and to be able to provide verifiable evidence of the fact that we've changed clinical practice. If we're lucky, we get 5 years, sometimes we get 10 years in which to demonstrate that we've made a difference and that we've been able to change things. Misoprostol has actually taken 20 years to actually develop the concept, to demonstrate that it was safe and effective, and then overcome a huge number of barriers around medico-legal issues, the associations between misoprostol and termination of pregnancy, which meant that people were very, very reluctant in that space to be using this kind of medication. We're just about to do a 12-month data set collection for the introduction of oral misoprostol clinically at the Women's and Children's Hospital. And we've done a series over 12 months. We have about 1,200 women who've had an induction of labour with oral misoprostol. We've got some really positive findings. So in 2006, after I finished my PhD, after we had the paper published, I was pregnant at the time, and I was asked by NHMRC to write a report called A Healthy Start to Life, really looking at current research priorities around maternal health. And it was partly because I was pregnant and wouldn't be putting in any grant applications that year, also partly because I was heading off to Canada as the Neil Hamilton Fairley Fellow. So I was in a position where it was seen to be impartial, and that's okay. So we wrote the paper and identified a whole series of priorities around perinatal health and women's health, maternal health. Maternal obesity came out as something that was really something that was under-investigated, but potentially becoming a really significant problem in terms of providing clinical care for women during pregnancy. The recommendations from the paper really were based on a whole heap of clinical guidelines where a lot of professional bodies had made recommendations to advise women to make lifestyle changes and to lose weight in the preconception period. So that was kind of the statement that was there. There was no evidence underpinning that recommendation, and there's still not a lot of evidence underpinning that recommendation. And there was only at the time a single randomised trial that had been done in pregnancy that was completely underpowered. It only had about 40 women in it. So we kind of had a talk, and I remember having a conversation with Jeffrey, and we were saying, it's great to intervene in pregnancy, but really from a developmental origins perspective, intervening in pregnancy is probably too little, too late. It's not going to have an effect. So we were really keen to investigate the preconception space, but I think also really, really cognizant at the time that there was no way on God's earth that we were ever going to get a grant funded to look at preconception health. It just wasn't the landscape of research or clinical care even at that point. So I kept those thoughts in the back of my mind, moved halfway across the world with our 6-week-old daughter at the time, Grace, and my husband, thinking, how hard can this first-time parenting gig be? I'm a sensible person, I can manage all of this. It was way more challenging than I ever thought it would be. We met a huge number of people who were great contacts and really great experiences, but it was not plain sailing by any stretch of the imagination. While I was in Canada, I maintained some of those conversations with Jeffrey, and we did put in a grant for NHMRC, a project grant at the time. And it was really focusing on what we currently did, the current prevailing paradigm. So for women with overweight and obesity, if we limit gestational weight gain, we will improve pregnancy outcomes. And that was kind of the understanding of clinical care at the time. And I came back to Australia in 2008 with my very first CIA NHMRC project grant, and we conducted the LIMIT trial, which was a randomised trial for pregnant women who were living with overweight or obesity. We recruited from South Australia around 2,200 pregnant women, so a reasonable sample size. And women were randomised either to receive standard care, which really was not anything in particular, it didn't provide them with any kind of information or advice about lifestyle changes or health during pregnancy, versus a dietary intervention that was reasonably comprehensive and provided across the course of pregnancy. Essentially, we showed that there was about an 18% relative risk reduction in the chance of a baby being born over 4 kilos, which has been associated with overweight and obesity. Women improved their physical activity and their diet, but they really didn't have any impact on any other clinical outcomes. So all the things that we thought we were going to impact really didn't make a dot of difference, didn't make any difference to gestational weight gain. Around about that time, the Upbeat trial, which Annette Briley, who's in the audience and has been a long-time collaborator, she was working on in the UK, and essentially, even though we were halfway around the world from each other, hadn't had any conversations about the type of intervention that was being delivered, there were so many similarities between the two trials that we had conducted. Both of them showed very, very similar findings in that there wasn't a great deal of difference. So we then had the challenge of publishing a negative trial, and I've taken the quotes directly from the journals that we submitted to. So we did the rounds, starting off with our high impact factor journals. And despite what journal editors tell you, they really are not interested in publishing negative trials. So they'll tell you that they will, but essentially it's really challenging to get a negative trial published. We did eventually find a home for it in the British Medical Journal, and we kind of, I think, have been challenged a little bit by the fact that it was a negative trial. And everybody when you're talking about it, I remember the first time I presented the findings, people were saying, aren't you disappointed that you didn't impact weight gain? It's like, well, it is what it is, really. The results are the results. We've also gone on and had a look in quite a lot of detail at following up the children, because potentially if there is a difference in birth weight over 4 kilograms, theoretically at least, there's a chance that that might influence childhood weight over the life course of that child. So we followed up the children at 6 months, 18 months, 3 to 5 years, 8 to 10 years, and we're just about to embark on 15 to 17 year follow-up. I've just got the little pictures down the bottom of the screen just to show, I guess, the context of how my kids have changed over that time. This has been a very, very long work in progress. Essentially, though, regardless of the way that we look at the data, regardless of the way we cut it, there really isn't any difference. So we haven't been able to impact gestational weight gain or clinical outcomes at all. And it felt very much like we were at this crossroad where we had a decision to make in terms of which way our research trajectory or which way our research path was going to go. So one option was what a lot of people were saying. There was certainly a lot of noise in the clinical space about, well, you just have to get the intervention right. The reason that you didn't find an effect is because you didn't have the right intervention. If you find the right intervention, you will make a difference to gestational weight gain. We listened to that for a little while. So we have done some studies looking at women with a normal BMI during pregnancy. We've looked at the addition of metformin, and essentially, again, makes absolutely no difference to the amount of weight a woman gains during pregnancy. So I don't think it's the intervention. We started to ask why, and I think there are a couple of aspects around the question itself. One of them is around gestational weight gain and what we're actually measuring with gestational weight gain. And I think it's very easy for a woman at the beginning of her pregnancy to stand on the scales, and then at 36, 37 weeks stand on the scales again. You have two weights, you subtract one from the other, and that's the amount of weight that you gain during pregnancy. But I think pregnancy is probably the only time in life where the weight that you gain is not actually fat mass. So, you know, for the average pregnant person, you have about a 3.8 kilogram baby, you have about 800 grams of placenta, you have about a litre of fluid, you have 2.5 litres of increased blood volume that is a physiological response to pregnancy. You have uterine hypertrophy to actually grow the baby. You have breast tissue hypertrophy. And if you're thinking about fat in terms of equating that relationship between fat and weight gain, it's less than 10%. So less than 10% of the weight that a woman gains in pregnancy is actually related to fat, and that fat is actually really, really important in being mobilised to support breastfeeding. So this whole concept that we can somehow modify gestational weight gain is, I think, a bit of a furphy. The other thing that we've done is look at systematic reviews, because there have been a couple of very high-profile systematic reviews in the literature which have made sweeping claims about interventions in pregnancy and how they are going to be effective in reducing particularly gestational weight gain, but also reducing gestational diabetes. And I think this is actually one of those moments where we really need to think about what we're saying, because across the board, systematic reviews will show about a 1 kilogram difference in gestational weight gain across pregnancy. It's really mind-boggling how sensible people can think that a 1 kilogram difference in weight gain that you're measuring across pregnancy to 37, 38, 39 weeks can impact something like gestational diabetes, which you diagnose at 28 weeks. Also, you know, we know that outside of the pregnancy space, a 1 kilogram difference is not going to impact your ability to change a diagnosis of type 2 diabetes or pre-diabetes. So it's hard to imagine how this can actually be biologically plausible. So we looked at a lot of systematic reviews. The literature is pretty rubbish, actually. There's a lot of really flawed studies, and I think if you toss everything in together, if you put rubbish in, you'll get rubbish out, and that's kind of the basis for a lot of the answers from the systematic reviews. We've also looked at causal pathways and actually looking at what is the relationship between gestational weight gain and pregnancy outcomes. And when you look at that from that perspective, there actually is no relationship. So there's no causal association between weight gain in pregnancy and any of the clinical pregnancy outcomes. So I think very clearly our interventions to target gestational weight gain, while it's a nice, simple concept, it's incorrect, and what we're dealing with is actually a much, much more complex problem. When we were looking at our causal pathway mechanisms, we did identify that a woman's BMI before conception is actually really, really strongly related to the outcomes that she has in pregnancy. And that kind of takes us back to that whole notion of preconception health and improving preconception health to really make a difference to pregnancy and to women's and babies' health. Begin Better is our preconception randomised trial. This is definitely a lesson in persistence. This is a grant that had its kernel of an idea back in 2006. It's gone through, I think, 14 grant iterations and submissions at varying time points. It was finally funded in 2019, and we've just finished recruiting 730 women across the state who are planning a pregnancy. So we delivered our intervention. We're just in the process of collecting our data, so hopefully very soon we'll have some information about whether or not this is an appropriate target. And I think definitely for me, sometimes the end of our gestational weight gain kind of story and journey really does feel like we've ended up at the beginning, where we started way back in 2006, and really highlighting that was the study that we needed to do. But it just wouldn't have happened in 2006. There's no way that we would have been able to have the reach that we've had in 2019, 2020, where we've been able to really utilise social media. That certainly wasn't a thing and wasn't a possibility back when we were contemplating this idea. I'm just going to finish very briefly with some key points. I've taken them from Albert Einstein because I think, you know, if anyone's qualified to make comment, I think he probably was. I think we forget sometimes that our education and our learning journey is not really about learning facts and being able to regurgitate facts, but we actually have to think, and I think sometimes we forget or lose the ability to think critically about the information that's either out there in the scientific domain or about how we ask research questions. I think it's really important to not stop questioning and to actually be that person, that annoying person that asks, but why? Why do we do that? Why is it that we've got ourselves into this position? What is it that we need to change in our thinking? I definitely agree with this next one. Persistence is the most powerful force on earth. 13 grant iterations, I think, is testament to the fact that you do absolutely need persistence if you're going to be successful as a clinician researcher. I think also persistence when you get those rejections. I mean, you spend ages sweating over a paper and finally push submit. I think it's very, very disheartening when within 3 minutes you get a rejection letter back from the journal editor's desk. It always is good to be pushing ourselves outside of our comfort zone. And I think that also applies to the work that we do, the questions that we ask, the collaborations that we establish with people. It's very easy, I think, to just sort of sit in our nice little space and not be challenged. But it is really important to kind of put yourself out there. And I have to remind myself that this is actually a really important thing, because I'm actually much, much happier sitting in the back corner than I am standing up here. I think the other thing that we've really found as a research group is that what is right is not always popular, and what is popular is not always right. We have faced enormous criticism for the work that we've done, and while I can accept criticism that's related to the work and the robustness of the work, I think we can justify that very, very, very strongly. I think it's really sad when some of that criticism becomes very personal, and people forget to separate the person from the project. That's all I really wanted to say. Thank you.
Thanks so much, Jodie. I think that was incredibly helpful. That was helpful to me. I'm sure it was helpful to all the audience as well, just to understand that sort of personal journey. There are people with microphones. Does anyone have a question for Jodie at this stage? Obviously, we're doing a panel, but about what Jodie presented, because I've got one to start with. Just Jodie, it was exactly related to that last quote, because I think it is really, I mean, I think what's great about what you do is you do challenge the norm or the current understanding or hypothesis and say, well, hold on, let's have a think about that. Is that really true? And I heard someone, actually your Amanda from your group, saying, you know, in research, we search for the truth. And so, you know, that's, how do you deal, I guess my question is, how do you deal with that situation where you really are going against the trend? How do you sort of manage that? Which I think you were getting to at the end there.
It's actually been really, really hard because Australia is a very small space. Obstetrics and gynecology is an exceptionally small specialty. So we pretty much know who's reviewing our papers, who's reviewing our grants, and it is really disheartening when the comments, and you can tell who's written the comments when the comments become very, very personal about you as an individual rather than about as your work. I think I've become much better at dealing with that. I remember as a relatively junior academic just being absolutely devastated by some comments that had come back from an NHMRC grant application that we'd written, to the point that with Jeffrey and Julie Owens, who was the head of O&G at the time, we actually made a formal complaint to NHMRC about the quality and about the nature of comments that had been included in the grant review. I think as you get older, you kind of maybe worry less. My daughter said to me the other day, we were having a conversation, and she was very concerned about what people in her class, so year 11 girl, very, very focused on what peer group is thinking, what her friends would think if she said this particular thing. And I said, well, you just have to not worry about it. Just if that's what you really think, then that's what you say. And she turned around and said to me, that's all right for you, you're 55 years old, I'm 16. And I think that's true. I think you just get to a point where you kind of go, well, it doesn't really matter. Yeah. You just develop a very tough skin.
Yeah. Any questions? Yes, Johan.
What can you say about mentoring? You had one mentor you mentioned. What can you say and advise everybody about mentoring and how to use them to your benefit?
I think mentoring is really, really important. I think Jeffrey is the person, I mean, he's passed away now, but he was always the person who I regarded very strongly as my mentor. I learnt a lot from Caroline Crowther in terms of research methodology, who was also my co-supervisor for my PhD. But there are a lot of people that you encounter who, just through conversations, they don't have to be from the same specialty or from the same field, who you can actually learn a whole heap from. So I think my thoughts on mentoring would be everybody needs a mentor. Everybody needs to find someone who they can have those conversations with. And I guess I actually really miss, since Jeffrey's passed away, he's been such a strong mentor for me, that even well after he'd retired, he still took an interest in the work that I was doing, and still would love to have conversations and debates and really push me to justify a particular stance. So I think having someone who is going to push you and take you out of that comfort zone is really, really important. You don't want, as a mentor, someone who's just going to pat you on the back and go, you're doing a fabulous job. You might be doing a fabulous job, but you actually need someone who's going to take you beyond that and stretch you in your thinking and the way you do things.
Any other questions? I'll just have... Oh, yes, thank you. Great.
How do you feel like your work and research has impacted, if at all, your clinical work or seeing patients, your obstetric work?
I think for me, my clinical work and my research work are very closely intertwined. So I find it actually really hard to separate one from the other, because the work that I do clinically very much defines the things that I read about, the literature that I question, the grants that I propose, the projects that I come up with to help the junior registrars learn about research. So, I don't think I can actually separate one from the other. And I think if I'm actually being a really good clinician, then I need to be really understanding research methodology and need to be really focused on what is the evidence base. And I think also just being prepared when you're sitting with the patient to actually say, I don't know. I don't know what the best thing to do in this situation is. I think sometimes as clinicians we feel like we have to have the answer all the time, but I actually think it's really important, and it's okay to say, I'm not sure.
Thank you.
Did you find it hard to try to take time off work to be able to do your research?
That's a really good question. I think at the moment I'm very fortunate in that I have my clinical position as well as an investigator fellowship. So that does provide me with, in theory at least, protected research time. I think the real danger is that as clinicians, clinical work can become all-consuming, and we always prioritise our patients, we always prioritise the clinical work that needs to be done. I think you have to be very disciplined about actually carving aside and having that protected time. And, you know, I think with the job that I do as the clinical director at the Women's and Children's Hospital, I've spent a lot of time structuring my diary so that people know, don't book meetings on this day. Like, you can book a university meeting, or you can book a research meeting, but you can't book a hospital administration kind of meeting. So just, I think, setting some rules and trying to stick to those rules, I find it easier if it's very compartmentalised. Otherwise, things just become way too chaotic. Yeah.
Thank you.
Adding on to one of the questions, how do you find a mentor?
I think it's initially finding people who you really gel with and who you feel like you can have that conversation with. So I think when you're going to meetings, having conversations with people, like, honestly, I'm the worst person to give advice about networking because I hate it. I really don't like going up and striking up a conversation with people that I don't know, but it is actually really, really important. Finding those people who you admire, whose work you admire, and whose work you aspire to be like, I think that's a really good start. And then initiating those conversations, and even if it's not a face-to-face conversation, if it's an email conversation, just introducing yourself. You know, I think you underestimate sometimes how receptive people will be. Yeah. Just put yourself out there.
Yeah.
Thank you for a really interesting presentation. Are you a mentor?
Yes.
Yeah.
Yes.
And how do you decide to give your valuable time? How do you decide that a person is worthy to receive your mentorship? Does that make sense?
It does.
Yeah.
That's a really hard question. I think if somebody's persistent, I think that speaks volumes. If somebody, you know, my door's often open, but if I'm in a meeting and people walk past, sometimes they'll look and that'll be it. But if they come back and actually really make the effort to pin you down, I think that's actually a really good thing. I think also, for me as a mentor, it works a lot better if you've got somebody who is self-motivated. So if you've got somebody who knows what they want to do, knows where they're headed, is happy to have conversations and be guided along the way, but is really self-driven, like they're the dream person to be the mentor for.
They should know what they want from you too, and come prepared.
Yeah. So people that turn up prepared for a meeting, who've got ideas, who, you know, just want to bounce ideas off you. I think, you know, they're the really exciting, interesting conversations, rather than it has to be driven by the person who's being mentored, not by me. So if you want a good mentor, or if you want to get the most out of that relationship, I think you have to come with an agenda. You have to come with your set of questions and the things that you want to achieve and get out of it.
I'm sorry if this is too personal, but this is a question for both of you. How do you balance training as a registrar and researching alongside of starting a family, like pregnancy, raising kids and things like that? It's a question for all the women out there.
I think it's a question for the women, but I think it's also a question for the men. I think for me, I am able to do the things that I do because my husband's incredibly supportive. He's not medical, so there's none of that inherent competition that seems to arise with different career paths. I think my husband is probably one of the most laid back. Sometimes you have to check that there's a pulse. He's a lovely man, don't get me wrong. But we, very early on in our relationship, made it clear that if we were having children, that we had co-parenting and it was equal. So Greg was a stay-at-home dad when we went to Toronto. He had 2 years of unpaid leave where he stayed in the apartment and looked after Grace. And that meant that I could go and make the most of the opportunities that I had at Mount Sinai and really immerse myself in that space. I don't think there's one right way of doing it. I think it's really a matter of working out with your life partner how that's going to work for you, because I know a lot of people who both work very, very busy jobs and will have an au pair who helps with the children, or have other ways with extended family who do that. So I don't think there's one right or wrong way to do it. It's a little bit of, just trying to work out as a family how that's going to work for you. And I'm sure if you asked Helen, I'm sure if you asked Alexia, I'm sure if you asked Annette, any of the women in the room who are successful academics who also have children, that they would each say something very, very different.
Hi Jodie, thank you for your talk. As a current PhD student, I guess one of my questions to you is, how have you found being a clinician kind of impact your research? Do you think you could do the same quality of research that you do now if you weren't a clinician?
I think my focus would be different if I wasn't a clinician. I think the questions that I'm interested in are really, they're central to the things that I see as part of every day when I'm working as a maternal fetal medicine specialist. They're the things that really drive me to ask questions and to think about what needs to happen next. I also think I'm very critical by nature, but I think that's a good thing when you're doing research, because I think it's too easy. There's so much hot air that gets out about hyped up findings, and being able to actually really look at those critically and go, well, actually, no, that's not what we're going to do, or that is meaningless, it doesn't impact clinical care at all. And I think that having the confidence to do that is something that develops over time. I certainly wasn't that confident when I was a PhD student. It's something that you grow into, and getting that balance between confidence versus arrogance. It's a fine line sometimes.
Thanks.
Thanks so much, Jodie.